So let me tell you a little bit about my TCAR journey, and I'm going to show you a case. I've been doing carotid endarterectomy for a long time, and along came transfemoral carotid stenting. Didn't seem like a great idea to me, but bought into it. It was many part of the clinical trials. And then along came Silk Road and said, no, we want you to do it through a cut down. Seemed like the craziest idea I'd ever heard. Why not just do a carotid endarterectomy? Well, it was wrong, actually. There is a big difference. And there's a big difference in what we put the patient through. There's a big difference in cranial nerve injury, as you heard from Dr. Wang. But I talked many times this morning about transcranial Doppler. That's what convinced me. So let me run this video first of all, and then we'll talk about how the new coverage decision basically has affected this.
This is successful transfemoral attempt. The patient is an 80-year-old male with asymptomatic severe right axial stenosis and a history of esophageal cancer treated with prior neck radiation. Given his age and prior history of neck radiation, we offer him transfemoral carotid artery stenting. Through right groin access, we used an H1 catheter and stiffing guide wire to traverse the arch and select the right common carotid artery without any high-intensity transient signals noted on TCD until contrast injection, which again confirmed the severe right axial stenosis on AP and lateral projections. The right external carotid artery was then selected, the guide wire and a 90 centimeter 6-French sheath was then placed over the wire just proximal to the bifurcation. A filter wire EZ was then used to cross the high-grade stenosis and deployed in the distal ICA with several hits noted on TCD at this time, signifying emboli. We subsequently attempted to cross the lesion with an 8 millimeter wall stent without pre-dilating, which is our standard practice, but were ultimately unsuccessful and again noted several hits on TCD despite the filter being in place. At this point, we chose to pre-dilate the lesion with a 2 millimeter by 20 and subsequently 4 by 20 balloon, but were ultimately unsuccessful at crossing the lesion with the same wall stent or subsequently with an exact stent, same size, as our sheath continued to kick back and not give us enough support. At this point, we decided to stop, given the extensive emboli on TCD, and recaptured the embolic protection device without issues. Our plan was to return to the operating room for TCAR versus endarterectomy. A small 2 centimeter vertical incision was made between the two heads of the right sternocleidomastoid, and approximately 3 centimeters of the right common carotid artery was exposed. The patient was fully systemically heparinized, and a single fibroproline first-ring suture was placed. A micropuncture needle, wire, and subsequent sheath were then inserted, and no hits were noted on TCD during dissection or cannulation of the artery. The tip of a short Amplatz wire is then inserted into the external carotid, and the 8 French Silk Road delivery sheath is placed and secured into position with a single silk suture. After ultrasound-guided access of the right common femoral vein, the 8 French venous return sheath is also inserted, and the flow reversal system is brought to the field, flushed, and connected. Passive flow reversal is allowed, and the common carotid artery is clamped proximal to the sheath, and flow reversal is then set to high. TCD confirmed flow reversal by flattening of the waveform in the MCA and subsequent recruitment of collateral blood flow from the circle of Willis, resulting in antegrade MCA flow. At this point, we inserted an 014 wire, and the lesion was pre-dilated with a 2 millimeter balloon, again without any hits noted on TCD now during flow reversal. A 9 by 30 millimeter self-expanding in-route transcarotid stent was easily placed across the lesion and deployed without difficulty, and again no embolic events were noted. Completion angiogram showed incomplete effacement of the stent, so a 5 millimeter balloon was used to post-dilate the stent. And no hits were noted during angioplasty, and completion angiogram showed complete effacement of the stent. Flow reversal was continued for 3 minutes, and then the carotid clamp is released, flow reversal is stopped, and antegrade flow in the right ICA is reestablished and confirmed on TCD. Blood was returned to the femoral vein, and the femoral vein sheath was pulled, and the 8 French carotid sheath is also removed, and the pre-existing fibroproline first-string suture is tied down. At this point, heparin is reversed, and hemostasis was obtained, and the incision was closed in layers. As noted, there's brisk upstroke in the MCA waveform on TCD, and the previously noted spectral broadening had largely resolved. The patient did well post-operatively and was discharged the following day. Again, this video demonstrates that TCAR is a reasonable option in patients who initially fail transfemoral carotid stenting and can provide the adequate support needed to cross a difficult high-grade carotid lesion. Thank you.
So anybody who wants to watch this is up on our YouTube channel. That DeBakey Cardiovascular YouTube channel is the biggest CV YouTube channel in the world. There's about 117,000 subscribers. So we'd like it, make it 120,000. So sign up for it. So how have things changed? And what's changed is that for a long time you had to be part of VQI in order to get reimbursed for the TCAR, but that had changed. And this with the carotid stenting, the CMS coverage decision, which expanded this in 2023, just last year. And there were changing requirements for reimbursement, and so as I said, we removed this mandatory data collection in VQI. But it does mandate that there's some sort of shared decision-making with the patient. And what that means is that the expanded Medicare coverage, we've extracted the most important data on the right side. Symptomatic greater than 50% stenosis, asymptomatic greater than 70% stenosis, extended coverage to patients not enrolled in a clinical trial, removed the previous high-risk surgical criteria, removed the carotid stent facility approval requirement, and added other criteria such as mandatory neurologic assessment, imaging, and shared decision-making. And so what does the shared decision-making mean? It means that you really need to know about all three different ways of treating the patient: transfemoral carotid stenting, carotid endarterectomy, and TCAR, and be able to discuss in a meaningful way with the patient what is going on. I strongly believe that one of the reasons they held back this coverage decision for many years is fear of the consequences. And the consequence is stroke. It's not just a little groin infection or a little bleeding. It's something that can permanently impair the patient. And so understanding what the nuances are of these various different approaches, there's absolutely a place for all three of these different strategies, and you may or may not be versed really in all of those. And so this is kind of what's mandated that gets discussed with the patient. And so you really need to be able to know about carotid endarterectomy, nuances of transfemoral. So why is there a difference between transfemoral and TCAR? It's really about crossing the aortic arch. And one of the reasons that we use TCD is you can see the embolization as and when it occurs. That example that I showed you, there was a huge difference in the amount of embolization. If you get successful flow reversal, and there are a few caveats really about that, then you will not see emboli hitting the brain. And, you know, I don't believe that there are any good emboli. I don't have enough brain cells, basically, to risk them. And so maybe some of you have got more cerebral reserve than I've got, but you can do this with essentially no embolization. And embolization occurs in a variety of different events. There are smart phrases which you can use. You can build into EPIC to make sure that you're compliant with this. So I think it's worthwhile understanding how this procedure is done. There's a simulator upstairs, so you can actually play with the en route. But for me, what sold it was it's as effective as carotid endarterectomy is in reducing the amount of cerebral embolization. Thank you again for the opportunity to present this today.